Okay, at this time, I'd like to invite Abby de Cruz to the podium. So, Abby comes to us from this company called Probably Genetic. I learned about this company several years ago, and I thought it's quite an interesting name. I also subsequently met with the CEO, and I've had interesting conversations with Abby as well. And I think that this session is a very nice segue to what we are all interested in, is basically improving access to diagnosis. A little bit about Abby. She has a PhD in clinical medicine from the Wellcome Trust Center for Human Genetics at the University of Oxford. Prior to Probably Genetics, she was a strategy consultant for Trinity Life Sciences, where she focused on cell and gene therapies for rare genetic disorders. At Probably Genetic, Abby works with different patient foundations to improve access to genetic diagnosis.
Thanks, Sangeetha. And I want to say thank you as well to Heidi and obviously Sangeetha and everyone at the ACD just for putting together this event, and of course for the opportunity to speak to you all today, which I'm really excited about. So just as an overview of what I'm going to cover with you today, I'm hoping to just give you an overview of us, who we are, what our mission is, and what drives us. And then spend some time on the how. So the how of what we have up here on the slide of finding undiagnosed patients faster. And then finally just show you a couple of examples of the kind of growth and insights especially that our programs can generate that we're really proud of. So hopefully after the next, I think 15 minutes or so, you'll have a clear idea of who we are and just how accessible we hope to make genetic testing. Perfect. Okay, so our mission at Probably Genetic is to diagnose 200 million rare disease patients. That's our driving force, and it's a hugely ambitious number for a hugely challenging problem. There's an estimated 400 million rare disease patients globally, and because of the challenges that exist in the space, we estimate, of course, around 50% of those remain undiagnosed. So our goal and what we try to do is to develop technology to find those patients and get them a diagnosis faster. So I just want to spend some time on that why, and many of the speakers have covered this today, and many in the room will have first-hand experience of the reality of this slide. But the why of us putting the company together and doing what we are, well, our driver in everything that we do is that experience of undiagnosed patients. And there's two key pieces here for us. And the first is that being undiagnosed means, on average, there we go. Being undiagnosed means an average of 8 years of not knowing why you or your child is sick, and we hear first-hand experience all the time of that number being much higher, much closer to 15 or even 20 years every day. So the diagnostic odyssey for these rare genetic disorders is incredibly long. And secondly, not only does it take many years, but of course these patients will often be given 2 to 3 misdiagnoses over that journey, which of course adds to that confusion and the uncertainty and the overall difficulty of that experience. So misdiagnosis and underdiagnosis, also huge problems in this space. And of course the consequences of the wait and the misdiagnoses for these conditions is that undiagnosed patients are unable to identify them, connect them to the resources, to the community, and potentially the treatments, if they exist, that they need. So what we're covering here is just that the experience of undiagnosed patients is our driving force, and what our goal is to reduce the time to diagnosis and the ease of accessibility of genetic testing for these patients. So I'm just going to spend some time on what I mean when I say we. We are a team of genetics and machine learning experts and also rare disease patients. So our founder and CEO that Sangeetha has met, Lucas and I, we did our PhDs in the same department at Oxford, which is where we met. And where Lucas, through his work on the 100,000 Genomes Project, had the experiences and the interactions with rare disease patients and their families at symposiums and conferences just like this one that led him to founding Probably Genetic. And rounding out the team, we have some engineering superstars that bring deep expertise in machine learning and natural language processing. and really importantly as well, rare disease patients as well that bring that first-hand experience of what it is to be searching for a diagnosis for years. So what we've put together as a team relies on one central notion, and that is that patients will surface online and look for answers online years before they get a diagnosis. And I'm sure there's first-hand experience of this in the room, but we hear every day of patients and their families, and especially parents, spending time on Google, searching for their symptoms, searching for things that their child can't do today that they could do 3 or 6 or 9 months ago. On Facebook, searching for communities, patient foundations, Instagram and TikTok, patient influencers we hear who are living with the experiences of the diagnoses that they're hearing about, and YouTube as a channel as well. So that's what the central notion for us is, and that's what we've based our approach on. So what our approach does or aims to do is that we find patients online using machine learning and, of course, genetic testing. So I'm just going to walk you through this pipeline that we've put together. And the first piece, as I mentioned, starts with that patient acquisition. And the goal here is to get the link to our Symptom Checker into every niche and corner of the internet that undiagnosed patients might spend time in prior to getting that diagnosis. So all of those channels that I just mentioned previously, we want patients to be seeing our link and getting into the opportunity to get testing much earlier in their journey. So the second piece is our Symptom Checker. So this is we refer to as a selection process. So what I mean by Symptom Checker is we've designed this to be as patient-friendly as possible. The goal for us here was that if you're a parent and you're in between a doctor's appointment and going to the grocery store and you're sitting in the car park, you're able to complete this, with sort of one hand on your phone in an average of 5 minutes. So incredibly patient-friendly to complete the Symptom Checker, and then once we get those submissions, that's where our machine learning technology kicks in and assesses those submissions and tries to nominate the best candidates based on phenotypic overlap and a whole bunch of other tech that we think are very good candidates for testing. So the next piece then is where we partner with an independent network of physicians who will review those submissions and order the actual tests. We conduct whole exome sequencing as our base test. And then that feeds into a fully remote testing pipeline that we've put together. So again, with the patient-friendly aspect at the center of it, we will ship sample kits out to patient homes. We have a variety of sample collection methods, and those patients can then ship those back to us and have the sequencing and analysis conducted. Again, fully remotely and inclusive of genetic counseling as well. So the final piece that accompanies the results aspect is the data sharing component, where we look to provide the organizations and the foundations that we partner with a really rich set of data and insights that are completely de-identified and can be enormously sort of useful and underpin the resources that patient foundations like the ACD and, of course, biotech and pharma partners who are looking to focus R&D efforts towards these sort of underserved disease areas. That's who we're looking to serve in the kind of data sharing part of the pipeline. So this is quite a high-level overview of our no-cost, patient-initiated, fully remote approach to making genetic testing more accessible for patients and hopefully getting them diagnosed. And I just want to mention, of course, it has to be high level given the time that we have, but I'm really excited to dive into any aspect of this program if any of you are interested in the Q&A and throughout the day. But given the time that we have, I just wanted to focus on 2 key pieces. And the first is just the sheer growth that we see in these programs. So we're able to phenotype thousands of patients within weeks. And this is example data from one of our programs that shows, so on the left, just the sheer scale of growth that we witnessed. We had over 10,000 submissions to our Symptom Checker come in just 4 months. And that curve, as you can see, is showing no signs of slowing down. And the other piece that's really important for us that centers on the accessibility part is, our goal is that if we had a patient-initiated, fully online, fully remote program, we'd have that sort of equity in geographic accessibility too. And that's sort of illustrated by the chart on the right, where you can see that we had, so what it shows is the location of each submission that's been anonymized to ZIP3 level. And we had submissions come in from all 50 states. And what's really exciting is that although this program was only active in the States, just through word of mouth and the sheer engagement that we see in these online communities, we had submissions come in from 22 countries around the planet as well. So the growth that we see in these programs is really illustrating the demand for this kind of approach. Now, the second piece that I just wanted to touch on centers on the data sets and the insights that our programs can generate. And our hope is that this will underpin sort of key resources for the organizations that we partner with. So one example of this that we've highlighted here is that prior to launching a program with us, we partnered with a patient foundation that had put together a database of treating physicians to create a care network resource for those in their community that were looking for a specific specialist or a physician near them. So prior to launching a program with us, they had 200 physicians in that database. And then 4 months after launch, this program's still running, we'd identified over 6,000 treating physicians that are serving members of this disease community. So this, again, is just one example, given the time that we have, of the insights that our programs can generate that can be really valuable for the organizations that we're looking to partner with. So, for the patient foundations, we're finding that we're really excited to support that improved patient education, the resources, building community resources for their populations that they work with. And then, of course, for our biotech and pharma partners, serving every part of the drug development pipeline. So from market sizing through to informing, especially locations of clinical trial sites, and then, of course, also driving recruitment for the trials that are in place already. So just to summarize, hopefully you all have a clearer idea of who we are and how accessible we're hoping to make testing, and also the value of this approach. Everything that we do is towards the goal of shortening that diagnostic odyssey and tackling underdiagnosis, and our kind of way that we're getting there is to make testing more accessible. So I'm really happy to walk in more detail about any of the insights that our programs can generate, but I'll just say thank you, and we'll look forward to meeting and speaking with more of you in the breaks.
Abby, before I let you go for a short period, I'm going to put you on the spot and ask you this question. So what I understood from your presentation is that individuals who are looking for a diagnosis can basically fill a form online and potentially get access to diagnosis without the intervention of a physician.
So the physicians are involved because they have to complete the test requisition form, but it's all completed. It's all sort of via the pipeline, so everything will be assessed. Okay. So the first assessment is based on the phenotypic overlap, and the second is to actually order the test through the physician network. So the physicians are definitely still involved in the process.
Okay, and are you able to comment on the cost of getting a genetic test?
Yeah, so the goal for us, with the accessibility piece is no cost. So it's no cost for the patients for all of our sponsored programs. We do have a sort of a direct-to-consumer option as well that lands at I think it's $1,200, and that's just skipping the part of requiring that sponsorship for the program. So you can still just complete the symptom checker and order a test that'll be, still go through the whole process, be reviewed by a physician. You'll still have access to the genetic counseling. It'll still be fully remote with all of those sample collection.
And no insurance required.
No insurance required.
Thank you.
Questions actually for probably genetics.
Okay.
Your algorithm that comes up with who's eligible for the free testing, how does that work, and what is the timeline to get results? Because there's parents out there that say, hey, I would like to get my son genetic testing, but can't afford it. And it's just simple stuff. So my oldest son, we knew there was something wrong from a month old, but it wasn't until he started having seizures that we really got the genetic testing done.
I'm going to run this mic down.
How we build this. So at the moment, the approach is disease-led. So what that means is when we build the machine learning, the algorithm, and what that really is a classifier, we'll try to, so when we're building the symptom checker, that's based on collating, there's a training phase where we'll build a prototype that's based on an internal review of all of the literature to try to collect all of the phenotypic terms that are relevant to that condition. That's what informs the initial prototype. And then in the training phase, that's the key piece, where we'll request submissions from patients or parents that have confirmed diagnoses of these conditions. And it's those training submissions that the classifiers are trained on in terms of, that's the kind of score of 1 in terms of likeness to those conditions. So that's kind of the training piece. And then every submission that we'll then receive to a program is sort of in a very high level way, there's an overlapping analysis that's done on the phenotypic profiles that kind of pings up of this is a candidate that really should be connected to additional resource, or of course, if the pipeline exists, funneled then through to the testing piece. No, so the confirmed diagnosis is just what we use to kind of establish the baseline reference point for the phenotypic profile.
If there's family history, does that get a score, essentially?
Absolutely. So the symptom checker one of the reasons why we're able to generate those insights that are really useful for foundations is that the symptom checker not only will collect that kind of phenotypic information for the patient, but also if there's family members that are experiencing symptoms, if there's family members that have had testing history done, or have a variety of physicians or whatever it might be, it'll take that into account as well, so that then if there is a candidate within a family that is identified as a candidate, as a likely candidate for testing, that immediately pings the additional submissions or the additional information that we'll have on the remaining family members, so that you can then kind of go on. Yeah, so it's 8 weeks from when we receive the samples back. That again, because it's a disease, the program's are disease-led at the moment, that can sometimes vary, where we have, difficulties for some of our pediatric programs, saliva collection is challenging, but we say 8 weeks from us receiving the sample will be for sequencing and then analysis, and you'll get that all within like a patient portal, so you can track it and then book your genetic counseling session to walk you through those results.
No, we have one more question in the audience, and we're over time, but people who would like to leave for lunch, please leave, but we want to...
It's a quick one. I just wanted to follow up on that and just ask, like, who is funding the testing, and for patients with what types of symptoms, and why?
Really invested in as well. So we have kind of 2 channels that we launch these programs through. The first is patient foundations, so just like the ACD, where it's initially, and it kind of varies depending on the size of and how well established some foundations are, but we'll definitely look to link up that first piece of the funnel, where we're trying to just see if we can develop a symptom checker that'll work for that condition or that disease area, because some, with a distinct phenotypic profile will be kind of a better match for a lot of these programs. So there's kind of the patient foundation piece, where there's definitely at least utility for that top of the funnel. But more often than not, for all of our testing, no-cost testing programs, that will be sponsored by biotech and pharma companies that either have R&D programs in place, where the whole goal is to just find more patients. And that might be because they're as advanced as they have clinical trials in place, and they're trying to drive patient recruitment, or they're just trying to understand more about what patients go through, about where the treating physicians are as well, and sort of be able to mobilize all of the resources that they have within their company, patient finding, patient engagement, physician engagement, all of these different aspects, trying to sort of target them for the condition that they're interested in. So the no-cost the majority of those are sponsored by biotech and pharma partners, but of course, the incredibly well-endowed patient foundations as well can look into that, because there is that shared interest of patient finding. Yes, we have to be, we like to err on the side of the patient finding piece, because for areas where there might be one therapy that's available, it's a little bit of a gray area in terms of how you can mobilize patient finding, because then any patients that you find will be directed to that therapy. But yes, definitely the majority of our programs treatments are in development, and clinical trials are either being planned or are currently.